Now, moving on to our last section, that is, we'll be discussing the secondary repair and amputation. We'll be discussing what are the principles of delayed repair, why we need to do the amputation at times as well, and what are the other options for late reconstruction as well. Why delayed repair is important sometimes, because there could be three kinds of delayed repair. This could be secondary repair or replacement of damaged structures. For example, there was a lot of wound and deprima, a lot of problems were there, and then we have to wait for it because the tendon length was not available. And then we have to wait. Once the wound heals, we can you go for delayed repair because now the tendon is actually retracted back as well. Other option is amputation of the fingers. This could be a delayed repair as well, in which that once the amputation of the finger is done, the tendon has to be sutured back with the bone so that it does not retracts and this muscle function is restored. And then it could be a reconstruction of mutilated hand. Now, delayed repair could be present in the case where there was a lot of injury, a crush injury was there, and once the edema has settled down, the bone is at least been looked into and some kind of fixator has been applied to, and then we can think of start repairing the arteries, veins and nerves as well, and then the tendon has to be repaired as well. Now, coming to the skin, if the skin cover is broken, we can go for a graft or a flap. And split thickness skin usually contracts. If this is applied over there, this will eventually contract. The best way is to actually go for the simplest to go for Z-plasty, and incision is made in such a way that it's actually in form of a Z, so that even if the skin contracts, it does not actually shorten the length of it. Other option is skin grafting, although it's rarely applied, but yes, it can be used as well. Local flaps, regional flaps, or free flaps can be utilized as well, depending upon if there is a massive wound and it's a lot of gap over there, then probably we can go for a free flap as well. But usually in hand, local flaps or regional flaps are more than enough. In case of tendons, primary suture is contraindicated as a primary repair if there is a wound which is contaminating it. Undue delay between the injury and the repair. For example, the patient comes to you after, let's suppose, more than 3 to 4 weeks, then probably we can go for secondary repair. Primary repair is not indicated. If there was a massive skin loss, then we have to first cover the skin because exposed tendon will eventually become necrosed. And inadequate operating facilities, which may be in case of certain countries in third world countries of the world, there may be inadequate facilities, so the patient has to be shifted to a proper facility. Therefore, it may take more than normal time. So in that case, sometimes the time has actually gone through and we go for usually a delayed kind of a repair rather than the primary repair of the tendon, which may fail. As far as the flexor tendon is concerned, injury to the profundus tendon, if it's only the zone 1, with intact superficialis, advancement retracted tendon is actually done. This may usually causes a flexion deformity. Tendon graft is also risky because get disrupted over here. Fusion or tenolysis of distal interphalangeal joint is reliable because this actually doesn't result in a stable interphalangeal joint or distal interphalangeal joint, and then we can tenolyse the tendon as well. If both the superficial and profunda tendons are divided, tendon graft is usually required if there is a large gap or the tendon has actually retracted to a back a lot of it. Therefore, a full passive range joint movement is prerequisite. If the joint is immobile or stiff, then even the tendon will not help, and tendon will eventually get either ruptured or the pulley will get avulsed because the joint movement cannot take place. So this important point is that joint should be supple, and once the joint is supple, then we can use the graft to and along the reconstruction A2 and A4 pulley so that the flexion at the finger can be achieved. Tendons excised from the flexor sheath are actually important because we have to sometimes excising it from the sheath actually remove the fibrous bands around them, and it helps in the excursion and causes them increase the movements of the tendon. This is usually done by formation and doing tenolysis. As I just told you, the tenolysis is actually done. The sheath around it sometimes gets stiff and causes the hampering of the tendons. Once after flexor tendon repair is done in zone 2, some active movement is indicating the tendon is intact. Therefore, the passive range of motion is good. Tenolysis of extensor tendon is usually done after the fracture because the fibrous growth which has actually formed after the healing, which may hamper the excursion of the tendon. Then what's important over here, the intensive programming of the movement is essential, because once we've removed the fibrous tissue, then once the wound is closed, we need to go for excessive physiotherapy so that the tendon does not again becomes surrounded by fibrous tissue. Coming to the nerves and the joint, sometimes the late presenting nerve injuries are actually assessed. Results of the repair usually deteriorate with time. It's ideal to operate or at least apply nerve graft as early as possible, as if the long process takes place, usually the muscle, foot and plates deteriorate, and eventually we may have to go for some kind of tendon transfer rather than doing any kind of nerve grafting. As far as joint is concerned, proximal interphalangeal joint is more prone to flexion contracture. Why? Because usually the extensor hood gets damaged. The head of the proximal phalanx actually buttonholes out of the two slips of the extensor tendon, leading to contracture. Therefore, active and passive exercises are supplemented with full range of motion. If stiffness persists, surgery is considered, but that is to further release of stiffness for the joint. Until unless the joints are supple, you cannot go for tendon repair. Then we have to look at the different ligaments which are surrounding the joints, whether what is actually there is a mechanical block or is it the ligament stiffness which is actually creating a lot of problem. Now coming to the amputation. Sometimes amputation is actually the prerequisites. It's rather a better option rather than repairing. If the extremity, or let's suppose if the hand is too mangled or a finger is too mangled, then even if we try to save the finger, later on it may become necrotic and ischemic and we have to amputate it. Then instead of the patient undergoing that sort of stress and problems, it's better to amputate early, save the as much as finger as possible, and so that the patient can go for rehabilitation. So finger amputation, although if it's painful or unhealed, then probably is an option as well. If it's a nuisance, we know it's gonna getting necrotic and it's problematic, then you have to remove it. If the repair is impossible, that is so mangled that you cannot repair it, first primary amputation is a good option. If it's associated with painful neuroma or psychological distress, and usually if amputation itself is something which has also associated with a lot of problems, but sometimes the primary amputation is the best choice or course of action. Now coming to the thumb. Thumb, as you know, it's a very important function in the hand, and actually for all the pinch and grip functions of the thumb, length of the amputation stump is actually maximized. Even if we have to actually thumb gets amputated, then this is very important that as much as length has to be restored of the thumb, which should be done. Stiff or deformed thumb, even if it's stiff, it should be worth keeping, because at least it will provide some degree of movement, which can be achieved with dressings. If there is local injury, then we can go for advancement flaps and neurovascular island flaps. This is advancement flaps being done. The dorsal surface actually mobilized and over the palmar surface. The cross finger flap, if it's involving the dorsal surface of the thumb, then we can go for a cross finger flap as well. But that is usually only if the dorsal surface is involved. Now coming to the fingertip amputation. Sometimes fingertips, this is very common occurrence, especially getting caught in or getting trapped in the door or something. This kind of injury usually occurs, and the finger may get amputated, or there may be a crushed injury of the distal interphalangeal joint as well as the distal phalanx. Then important point is that you have to first go for the assessment, meticulous hemostasis, and then we can go for cross finger flap of this finger over this, so that once the tissue happen over here, we can advance that to cover this whole area. Sensation is really limited, but yes, at least it looks relatively simple, and at least the wound is closed. Flexion contracture can develop at the donor side because the finger will be placed in certain position for a long period of time. Final choice depends on the patient's requirement and surgeon skills. It's important that the patient has already a distal phalangeal fracture and it's already partially amputated. Then primary amputation can be thought as well if we are expecting that the prophylaxis is not heal. But if the patient needs a lot of hand skills later on for the functioning, then probably the advanced flaps can be done so that the patient can have this finger function restored. Coming to the digits, Index finger is usually not amputated at the primary interphalangeal joint level. And why? Because if your index finger is actually proximal interphalangeal joint level is amputated, this actually interferes with the thumb function. So it's important, if you have to amputate it, amputation is done at the base of the proximal phalanx, which is more acceptable, as you can appreciate it over here. Middle finger, ring finger are usually not amputated through the knuckle joint, that is at the metacarpophalangeal joint. And why? Because whole of the finger is once amputated, then it's important. Extensor tendons are usually never sutured back to the flexor tendons. Rather, the hole is drilled over here in the metacarpal heads, and actually they're sutured back into the metacarpal heads. Why? Because if you suture them to the flexor tendons, then they will antagonize the function of the flexor tendons. As a result, there will be decreased movement of the other fingers as well. And for proximal injuries, entire finger can also be amputated sometimes as well. In form, for example, there could be a re-amputation as well, in which involves almost the head of the metacarpals along with the finger are removed and blocked, and later on the wound can be closed. Later reconstruction, if the thumb, for example, is being lost or amputated during the injury, thumb is very important for the function of the hand, therefore thumb has to be restored. There are multiple options. One is policization, that is, you take one of the finger, index finger, rotate it back and put it over here in place of the thumb, and this finger, index finger, can act as a thumb later on. Other option is microvascular free transfer of the second toe. The toe is amputated, microvascular anastomosis done between the arteries, and actually the toe thumb, it's called as toe to thumb transfer, is actually done. Other option is osteoplastic reconstruction, that is, we can apply a bone graft, attach it with the orthodontic carpometacarpal joint, and then cover that bone by a form of a advanced skin flap or some kind of a flap by which we can, although that thumb will not function properly, but although some degree of function will be present over there as well, because the bone is actually attached by has been orthodized to the joint. And if all fingers are lost and thumb is present, new finger reconstructed with free toe transfers or osteoplastic digit, that is, you apply a bone over here and then you cover that with soft tissue to form a finger. But the best option is to use actually second to fifth toe, and toe to hand transfers can be done as well. In this section, we have briefly gone through what are the sometimes when we have to go for delayed reconstruction, what are the different procedures for going for different delayed reconstruction. Usually, if there is a massive wound injury, we have to wait, or if the patient is presented quite late, then we have to go for a delayed repair, because either the graft length is not available or the graft tendon has actually retracted so much that it needs a two-stage repair. And then if two-stage repair is done, the first stage, what we do is we go for it, we form a tunnel around it and apply a hunter rod, or called as a silicone rod. And that silicone rod is placed in this, and the soft tissue is actually repaired over it. Once over 2 to 3 weeks, the soft tissue heals and it forms actually a tunnel. Then we again go for the second surgery, remove the hunter rod, and we actually pass through the tendon through that either the tunnel, or what we can do is we can use the graft to pass through the tunnel, and which can later on will prevent the bowstringing as well of the tendon, and we can suture it with the primary tendon. Therefore, two-stage reconstruction and daily reconstruction can be done. Other options include is actually go for a primary amputation, where if the finger or the hand is too mangled, or eventually it could be more problematic for the patients later on. Therefore, primary amputation is always a good option in a severe crush injury. Thank you very much. Keep watching sqadia.com.